Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 516 of our pharmacotherapy series, which majors in chronic kidney disease. This case applies to patient WKS in parts 514 and 515 of this pharmacotherapy series. My first question to you reads: does WKS's hypothyroidism have any relationship to her chronic kidney disease? What other endocrine abnormalities are associated with uremia? Disturbances in thyroid function are frequently encountered in patients with CKD because the kidney is involved in all aspects of peripheral thyroid hormone metabolism. Common laboratory abnormalities include reduced serum concentrations of total thyroxine, abbreviated as T4, and 3,5,3'-triiodothyronine, abbreviated as T3, and a low free thyroxine index, abbreviated as FTI. The thyroid-stimulating hormone, abbreviated as TSH, concentration is usually normal, but peripheral conversion of thyroxine to triiodothyronine is reduced in uremic patients. Despite these abnormalities, clinical hypothyroidism does not occur solely as a result of kidney disease, probably because the amount of free, unbound to protein, thyroid hormone in serum remains normal. Hypothyroidism in patients with kidney failure should be confirmed by the presence of an elevated serum thyroid-stimulating hormone concentration and a low serum concentration of free thyroxine. Other endocrine abnormalities that have been observed in patients with CKD include gonadal dysfunction leading to impotence, diminished testicular size, menstrual abnormalities, and cessation of ovulation. Decreased libido and infertility occur in both sexes. Uremic women of childbearing age should be counseled on the risk of becoming pregnant because of the multiple complications of pregnancy in end-stage renal disease, including high termination rates. My next question to you reads: other than the obvious effect of WKS's diabetes mellitus on blood glucose, are there any effects of kidney disease itself on glucose metabolism? Uremia often is associated with glucose intolerance early in the course of kidney disease in non-diabetic patients. Specifically, patients with CKD often exhibit an abnormal response to an oral glucose challenge and have sustained hyperinsulinemia. The fasting blood glucose is typically within normal limits. Diminished tissue sensitivity to the action of insulin is also observed. Inflammation and oxidative stress are likely contributors predisposing CKD patients to insulin resistance. Most non-diabetic patients with kidney disease do not require therapy for hyperglycemia, and dialysis can correct these abnormalities in glucose metabolism. Patients with diabetes mellitus and advanced kidney disease may experience improved glucose control and decreased insulin requirements. This is because the kidney is responsible for a substantial amount of daily insulin degradation, and, as the disease progresses, less insulin is cleared and its metabolic half-life is increased. A decreased clearance of insulin by muscle tissue also can occur in patients with uremia. Thus, in diabetic patients with progressive kidney disease, blood glucose concentrations should be monitored and insulin doses adjusted to avoid hypoglycemia. Patient WKS has CKD5D and is receiving her insulin in the peritoneal dialysate solution. Hyperglycemia is also a concern in patient WKS, because the glucose present in her continuous ambulatory peritoneal dialysis fluid to promote fluid removal will be absorbed systemically. Insulin dosage adjustments should be made on the basis of repeated home blood glucose measurements, changes in the continuous ambulatory peritoneal dialysis prescription, and glycosylated hemoglobin determinations. 1 month before her current clinic visit, WKS complained of nausea and vomiting of partially digested food. Metoclopramide, marketed as Reglan, was begun at that time. So my next question to you reads: could WKS's nausea and vomiting have been caused by her kidney failure? Was the appropriate therapy selected? Gastrointestinal abnormalities are extremely common in patients with CKD and include anorexia, nausea, vomiting, hiccups, abdominal pain, gastrointestinal bleeding, diarrhea, and constipation. Diminished gastric motility can occur from uremia. However, this problem may improve with adequate hemodialysis. Dyspeptic complaints and gastroparesis may be more prevalent in the peritoneal dialysis population than in the hemodialysis population and in the earlier stages of CKD. Patient WKS has diabetes mellitus and diabetic neuropathy, which also contributes to the delayed gastric emptying, that is diabetic gastroparesis, and retention of food in the upper intestinal tract. This frequently causes distension, nausea, and vomiting. Metoclopramide is recommended to relieve these symptoms, although the risk for extrapyramidal side effects should be considered. A lower dose of 5 mg before meals may be warranted for patient WKS. Severe uremia also causes nausea and vomiting, and these can be initial presenting symptoms of kidney failure. At this stage of clinical presentation, dialysis is the preferred therapy. Drug-induced nausea and vomiting always should be considered because patients with CKD often take multiple drugs and are at risk for drug toxicity because of diminished kidney function, e.g., digitalis intoxication. During her clinic visit, WKS reports that her bowel movements have become black and tarry in appearance. A rectal examination reveals guaiac-positive stools. My next question to you reads: is GI bleeding related to kidney failure? Patient WKS should be evaluated for peptic ulcer disease and lower gastrointestinal bleeding. Uremic patients are at risk for bleeding from mucosal surfaces such as the stomach. Angiodysplasia of the stomach and duodenum, as well as erosive esophagitis, are the most common causes of bleeding in patients with CKD. Treatment of upper gastrointestinal bleeding in uremic patients usually consists of cautious use of H2 receptor antagonists, which should be given in reduced doses according to the degree of kidney function. Proton pump inhibitors are primarily eliminated by non-kidney routes and can be administered at standard doses. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 517.